Finally, after all of that, the A&P, the electrophys, how to put leads on, how to read them, how to analyze, let's actually finally look at some rhythms, huh? Well, we're going to start from the top of the heart working down. So we're going to do sinus or atrial rhythms. So that's going to be ones coming from the sinus node, the right atrium, or the left atrium. I'm not really going to specify one or the other than sinus node beats. Just realize that atrial rhythms could come from any one of these locations. All right, mechanism of sinus rhythms. Well, quite simply put, the pacemaker is the sinus node. As promised, we're going to start with what's normal. Now, this diagram over here, get used to it because that's what I use to mark out the beginning of every single rhythm we pretty much go through in this class. And so here is your SA node or your sinus node, and that's where all these rhythms will start. Now, it regularly initiates impulses at a consistent rate, and they are conducted normally through the ventricles. Not much more complicated than that. So, what are the rules for sinus rhythms? Well, basically we divide those up on what the rate is. So if you have a rate less than 60, that's sinus bradycardia, also known as SB. If you have a rate between 60 and 100, well, that's going to be normal sinus rhythm, or just sinus rhythm. And if your rate is greater than 100, you've got sinus tach. Now, it's going to be regular. There are going to be no patterns at all. It's just going to be sinus rhythm. Now, your P waves are going to be absolutely perfect. They're going to be uniform, 1 P for every QRS. Your PRI will be perfect. It's going to be between 0.12 and 0.20. And of course, your QRS is going to be less than 0.12, but of course greater than 0.06. And so this is the most natural rhythm that your heart can produce, normal sinus rhythm. This is what it should look like when everything's functioning correctly. I'm not going to go through and do everything, rate regularity, the P wave, PRI, QRS. All the rules are on that slide before this. But what I do want to draw your attention to is this. Every single P wave is identical. There's 1 P wave for every QRS, and everything is nice and regular throughout here, and that's what makes normal sinus rhythm normal. That's what it's supposed to look like. Please keep in mind the rate. If it's greater than 100, then you're looking at sinus tach, and if it's less than 60, you're looking at sinus bradycardia. So even though there's not much to say on this slide, I'm doing it to establish a pattern from what you can expect, which is talk about the mechanism, talk about the rules, give you an example of how to actually figure it out, and then go through and explain why that certain rhythm is important. And in the case of normal sinus rhythm, the reason it's important is because that's what's normal. That's what it's supposed to do. It doesn't produce any symptoms because it's normal. So that's the shortest way I can say that, honestly. Now, sinus bradycardia, on the other hand, does give us, a few trips here and there. Why is sinus bradycardia important? Well, if it comes out of nowhere, if it's new, it can be a prequel to other problems like blocks or even asystole in the worst case scenario. And what does it produce when it's going badly? Well, you'll have a slow, regular pulse, but if that pulse is too slow, let's say way down in the 30s or worse, that can actually cause signs and symptoms of decreased cardiac output, also known as CO. And we'll talk about that in just a little bit. What can cause sinus bradycardia? Well, well-trained athletes, Olympians, frequently have heart rates in the 30s because they're so dang healthy. I'm sure the CrossFit kids have the same problem, so to speak. But problems that can actually cause it would be an MI, myocardial infarction, vagal stimulation. We talked about that a little earlier with the carotid body stimulation and how syncopal episodes can come from that. Or increased intracranial pressure. That's a late sign of high ICP that we watch out for sometimes. One other item that's important for sinus bradycardia is not only the new onset, which I'd mentioned, it's also when it's not responsive to stimulation. So if your patient's bradycardic, you go in there and you're doing a sternal rub and they stand up and they look at you and they're talking wide awake and their heart rate doesn't budge from a bradycardic number, that's a sign that it's inappropriate at the time. So finally, sinus tach. Why is this one important? Well, normally sinus tach's not a problem. It's a natural response to a lot of different stimuli. But in the case of acute myocardial infarction or a heart attack, that can actually make the heart attack worse. If you think back to what we were talking about with the O2 needs of the heart, that diastole is super important. And when you're tachycardic, you have less diastole. So in an MI, when you're not getting enough blood flow already, speeding up your heart increases how much oxygen the heart uses and cuts down on the amount of time that the heart has to replenish itself. So that's one area where sinus tach is actually pretty decent. Clinically, what do you see? You see a rapid regular pulse. If it goes on for too long, they might become symptomatic. And by prolonged, I mean, hours to days, depending on how healthy the individual is. It can cause palpitations or dyspnea sometimes. What triggers it? Well, when you have hypovolemia, so when you're dehydrated, or relative hypovolemia, like in severe sepsis or septic shock, any kind of shock for that matter. If you're in heart failure, people who have late-stage heart failure are frequently tachycardic because that heart's having a tough time doing its job. Fever's a great one. I've had plenty of patients that they're tachycardic when they're febrile. You break their fever, tachycardia goes away. Activity does it. Back to those CrossFit kids and Olympians that are working out. Pain does it. I'm sure we've all seen this, and the anxiety that goes with that. All of these items are stress, and that just brings up your heart rate. So, last thing I want to say is when we become symptomatic, that's another way of saying decreased cardiac output. So I've mentioned it a few times. I need to finally sit down and explain what cardiac output actually is. So when you have decreased cardiac output, it's a sign that you're not getting enough blood flow to the areas of the body that you need to. And so your body responds in a fairly consistent manner. And you can have any combo of these. It can be as generic as anxiety, or just chest pain, shortness of breath. Maybe they're sweating a little bit. Hypotension's a very obvious one. That's why we get vital signs on patients as soon as we can. Cool, clammy skin can come with that. Cyanosis, because they're not actually moving enough blood through their lungs, potentially. And then this one here is decreased LOC, which I think is probably the most important one, in my opinion, because you have to lay eyes on your patient. One of the first signs that someone's got a low cardiac output may be that they're less responsive, they're more sluggish, difficult to rouse. So you gotta check the patient, check the vital signs, and slap a telly on them if you can, just to see if the heart rate or the heart rhythm has anything to do with that. But when I talk about decreased cardiac output, it's any one of these items happening together. All right, so let's talk about a flutter, atrial flutter. This arrhythmia arises from a single irritable focus within the heart, atria specifically, that fires off rapidly and repeatedly. And it's firing so fast that not every single impulse is actually able to make its way through the AV node. In fact, there's the absolute refractory period. That prevents that AV node from responding to every single one of these beats that comes through. And so it leads to an intermittent block or intermittent conduction. The ones that do go through conduct normally. And so what really makes a flutter kind of cool is the fact that it just cycles over and over and over again as quickly as it can, which is what gives it its characteristic sawtooth appearance. The rules for atrial flutter include two parts. You actually have to look at this at the atria and the ventricular rate separately. And so that atrial rate is going to be in the 250 to 350 range because those P waves keep happening at such a rapid rate. It's just one after the other. Whereas your ventricular rate, depending on how often it's being blocked, you're going to have QRSs that pop up in different locations, and so you'll have a separate rate for those. The atrial rhythm is actually going to be very regular, but the ventricular rhythm is usually regular, but in the cases where the block is variable, that can create irregularities. Your P wave is going to be super unique. It's going to have that characteristic sawtooth pattern. You won't be able to get a PRI because it's just one P wave after another. But your QRS should be normal. Okay, and so this is atrial flutter. If you recall from the previous slide, there's all the rules down there, but this is what we're talking about with the sawtooth P waves. So through here, what these guys look like. In terms of a conduction ratio, it's how many teeth there are for every QRS, or actually how many P waves there are for every QRS. And so I just want to make note here that you've got 1, 2, 3. I'm going to do this in a different color. And so this is atrial flutter. Things that I want you to keep in mind, this is what I'm talking about when I say sawtooth pattern for the P waves. It's these guys here. The other important things is how many of these saw teeth there are for every single QRS. And so the way we would count that is we'd start with 1 right here, and then there's 2 and 3. So 1, 2, 3, and then you've got a QRS. So you've got a 3-to-1 conduction there. But that's essentially what a flutter looks like. So why is a flutter important? Why are we bothering? Well, the big reasons that we get excited about a flutter is first, you lose that atrial kick, which means you lose your cardiac output, or it drops significantly, I should say, of about 20 to 30% of your blood pressure and everything that you can muster just falls off as soon as you lose that atrial kick. So that's one really big important thing. And the second big thing is your emboli risk, your chances of developing a clot in your heart and then kicking it out into somewhere else. So to kind of go through these both, the drop in cardiac output can quickly lead to a lower cardiac output, particularly with a rapid ventricular rate. It's actually kind of funny. The faster the heart rate goes, the odds of you having a drop in cardiac output are a little bit higher, which will only compound other problems, like if you already are having a heart attack, if you already have heart failure, or if you already have emboli in there, that can actually cause them to be kicked out or dislodged and moved to the rest of the body. Who's most likely to wind up in a flutter? Well, people who've had atrial stretch, and so that's pulmonary patients. They're most likely to have this. People on antiarrhythmics, actually the drugs you take to go from a fib to try and fix that can sometimes cause you to be in a flutter, particularly amiodarone. So it's not uncommon to see that combination. And cardiac surgery, anytime you, make the heart angry. And yes, we're drawing in green because the Hulk's involved. No, not really. But still, cardiac surgery irritates the heart. That's one of those triggers for sure. So keep in mind, emboli risk, because those can go to the lungs or to the brain. and drop in cardiac output, which then just decreases all of your faculties at that point. Okay, let's talk about atrial fibrillation. This one's really neat because you have ectopic pacemakers. It's actually a multitude. The best example I can give you would be like raindrops on a puddle. It's just pure chaos, right? Those drops are hitting multiple at the same time in multiple areas, creating ripples that collide with the other ripples nearby, and it just makes a whole mess. And so that's the idea, is that on the left side of the heart and the right side of the heart, there's just a mess of these going off simultaneously. There's no organization whatsoever. And because of these impulses firing, it creates fibrillatory muscle movements. It's bag of worms is another way people like to describe that. And that's actually something that we pick up on the EKG as F waves. Not terribly unlike your artifact from muscle shivering, except way more sublime. It's really tiny, mostly impossible to see in a lot of occasions, and we'll go through some examples of that. The next important thing, and what makes a fib similar to a flutter, is that AV node blocks some of these impulses from getting through. And the best way I can describe that is, you know, those buildings and those fancy hotels that still have the revolving door. Well, if you've ever seen a crowd of people try to go through one of those, that's a lot like how this works. Sometimes 3 people will cram in and they'll all get through, and then just 1 person, and then maybe 2 people, and then it may go a whole rotation with no one going out at all, and then there'll be another 2 people. It's just absolutely regularly irregular in terms of what your conducted impulses do, the number. Once they get through the AV node, they conduct normally and they look just fine. So, rules for atrial fibrillation. Well, we, like many other rhythms, use different names based on whatever rate it's traveling at. And so if you're going less than 60 beats per minute, that is AFib with slow ventricular response, or SVR. So there's no such thing as bradycardic AFib. You actually call it atrial fibrillation with SVR. Now, if you happen to be in the rate of 60 to 100, that's simply controlled AFib, meaning that heart rate has been controlled to the point where it's within a normal range. Anytime it gets above 100 beats per minute, that's what we call AFib with rapid ventricular response, RVR. And it's important to make those distinctions because you don't want to call it tachycardic AFib. Oh no, it's AFib with RVR, AFib with SVR, meaning slow, fast. Irregularity from both a ventricular and atrial standpoint is just grossly irregular. And as I had mentioned before, regularly irregular. No discernible P waves. You shouldn't be able to see any. If anything pops up, it's going to be these fibrillatory or F waves. If you don't have P waves, you can't measure a PRI, but your QRSs should all look just fine. Here we have atrial fibrillation with RVR, rapid ventricular response. So this is faster than 100 beats per minute. The things I really want you to focus on with this is, one, what that isoelectric line looks like, how it's just completely all over the place, it's undulating constantly. That's what we're talking about when I say F waves. It's just fibrillatory. The other thing I want you to take from this is that the QRSs are all over the place. There's no 2 that are in the same spot ever. Their distance is always a little bit different from one another, and that's that intermittent conduction that's going through the AV node. Other thing I want you to keep in mind, if your rate is, between 60 beats a minute and 100 beats a minute, that's just AFib. And if your rate is less than 60, that equals slow ventricular response. The only other thing is, yeah, you have no consistent P waves here whatsoever. So what's so important about AFib? Why are we looking at this? Well, for number one, it is common. We see it all the time. In fact, you are more likely to go into AFib the longer you live. There's some specific formulas for that, but it kind of boils down to the idea that by the time you're 90 years old, you're almost 100% likely to have AFib by that point in your life. But more importantly, it's very similar to A-flutter in that, you know, you get that rapid rate plus the fibrillation of your atria, and that causes loss of your atrial kick, which causes decrease in cardiac output by 20 to 30%. And additionally, there's that extra high risk of emboli, even worse than with A-flutter. So with the decreased cardiac output, of course, you can get these signs and symptoms of that. And with your emboli risk, which is over here in the outcomes section, you can have it to your brain, which is, of course, stroke. That's why when someone presents with the stroke, one of the first workups we do is getting a 12 lead to see if they have AFib or not. And, of course, pulmonary embolisms in your lung. Now, if you're in AFib, you've basically bought yourself some treatment, and that's going to be anticoagulants. And maybe even some antithrombotics to help reduce the risk of you making emboli that may cause trouble down the road. Other treatments include a cardioversion to try and kick you out of that rhythm if medications are unsuccessful. What triggers it? Well, atrial stretch. You know, you almost liken it to when you have wires, that if you stretch out wires, they start sparking and arcing across one another. And AFib kind of works that way. You stretch out the heart, those are electrical little muscle fibers, and they can start making sparks of their own. Hyperthyroid, because that just tweaks your heart a little bit, just makes it more likely to be reactive. Cardiac surgery, go poking around. Of course, it's likely to be irritable. And of course, digoxin can easily throw that off as well. Last thing I want to touch on is this section here. You are definitely going to have an irregular pulse. It may be fast or slow, just depends. But one of the things we frequently see on our monitors is a patient's in AFib, it's really irregular and it's running fast. And so their heart rate, which is your telemetry, reads like 110. But then your pulse, I'm going to change colors for this, your pulse reads 95. And so the question becomes, which is correct? What's going on? If I record my vitals and say their heart rate's 110 but their pulse is 95, am I lying? Am I incorrect? What did I do? How did I screw up? Well, the reality is when the heart rate is going really fast, some of those heart rate impulses don't actually move any blood. And so what happens is you wind up with a pulse deficit. So it's always important that just because your patient has a high heart rate, don't assume their pulse matches. Go check it manually, get your hand on their wrist, do those kinds of things. But that's what I'm talking about when we talk about heart rate versus pulse. We'll touch on that with a few other things later on in the presentation. Last but not least, one of the number one things that you'll present with your first onset of AFib is going to be syncope. That's right. You're most likely to present with episodes of passing out as one of your reasons for getting medical care. Supraventricular tachycardia. What the heck is it? Well, essentially the idea is it is a very fast rhythm that is being generated by either the atria or the AV node. It's everything that is above the ventricles. That really doesn't tell you a lot, though, does it? It just says that, hey, it's above this area, and that's the most I can say. It's not an accurate description, and the reason we use this is because P waves usually aren't visible. That's the big part that helps lead us to this. To try and illustrate what I'm getting at, I'll ask you this question. What has 4 legs, is furry, and barks? Well, of course, it's a dog, right? It's not too hard of a question to ask. Most everyone's seen a dog. They have a basic idea of what they look like. However, a lot of different images can pop in your head what a dog means to you. Now, if I was to say Chihuahua or Saint Bernard, you'd immediately be able to picture 2 very different animals in your brain, you know, big one, small one, a lot of fur, practically no fur at all, things like that. And if I was to say Black Lab versus Chocolate Lab, essentially the same dog, except for there's a color variation between them. And that's the idea of any of the naming we do with rhythms, is to say the most exact one that we can, so then you can get a better picture in your head of what you're up against. In the case of SVT, supraventricular tachycardia, it's the best answer that we can get. You know, we can hear a dog barking, so we know it's a dog, but to be able to tell more from it, it's very difficult. So what this comes down to is the 2 most important things, which is one, treat the patient. 2, slow it down. When these rhythms are going on, you really need to take care of the patient first. If they're having blood pressure issues or whatever, fix that, and then work on figuring out what kind of rhythm you're dealing with. If they're just falling apart, maybe fixing the rhythm is what you need to do. That's where ACLS comes in. And we have different things to deal with it in that pathway. So, moving on. So, supraventricular tachycardia rules, SVT. It's gonna be fast. One of the faster rates you may encounter. But it will be quite regular. That's one of its hallmarks, is that it's going so fast that it has no choice but to be regular. You're not going to be able to see any P waves because they're likely hidden in the preceding T wave in most cases. So, because you don't really have a P wave, you can't have a PRI. And lastly, your QRS pretty much always should be less than 12 seconds. It should less than 0.12 seconds. It should be narrow. This is supraventricular tachycardia. The big things I want you to take away from looking at this strip is just how fast it is. If we count these out, there are 22 beats. So 22 times 10 equals a heart rate of about 220, which is crazy fast. And if you look here too, you can see how the T waves and the P waves, you can't really differentiate them from one another. They kind of blend together, so that it's impossible for me to tell, is this a fib? Is it a flutter? Is it just sinus tach that's going way, way, way too fast? I can't tell any of those things for certain, so I have to just call this SVT, which is fine because treating the patient with a high heart rate, that's what matters, and we'll talk about that in the next slide. But yeah, just keep in mind this is that hallmark, is that it's fast and that you really can't find your P waves at all. Why is SVT important? Well, the biggest part of it is that the rapid heart rate can really drop that patient's cardiac output. That's the biggest concern that we have, or the most pressing concern that we have when someone goes into SVT. In fact, we divvy them up into stable and unstable. Now, if they're stable, that's good. It means they're maybe just a little lightheaded, but otherwise they're in pretty good shape. And we can work through it. We can diagnose the rhythm, and we can treat it with meds. Nothing terribly emergent. However, if they're unstable, and so those are those signs and symptoms of decreased cardiac output. So chest pain, maybe they're short of breath, sweating, hypoxia, hypotension. If they have any of those types of things going on, we're actually going to follow ACLS and do what they would do for narrow complex tachycardias with symptoms. Current recommendations at this time are doing things like vagal maneuvers, you can also try adenosine. And that drug dramatically slows heart rate. And if that doesn't work, or if you're running out of time because they're getting worse rapidly in front of you, synchronized cardioversion, one of the most important and fast-acting ways to try and correct these problems. Regardless, you need to have someone who's certified in ACLS to be directing these actions. Don't do anything like this unless you have your ACLS. And even then, try and get someone with more experience to come in. Ultimately, what's going to trigger all this? Well, it's going to be your so a reentrant rhythm is going to be one of those. So maybe they already had a tachycardia of some kind and it just got out of hand. Drugs, your digitoxicity, get a level on those. Maybe their ectopic rhythm, again, just got worse. Ultimately, the problems that come with SVT are what happens if it goes on for too long. And so that's things like heart failure, because your heart's working at a very, very fast rate without slowing down. If you got any kind of coronary problems already, that's just going to make that worse. And ultimately, it could lead to shock, where you get fluid backed up in the lungs, so now you don't have enough oxygen, and so your heart and your lungs kind of crap out, and then you're in for a whole world of hurt. So this is why we take SVT very seriously, and we try and treat it as quickly as we can. As promised earlier, this is a graphical representation of how SVT encompasses so many different other rhythms. So you have SVT here at the top, and you'll note that it starts at 100. Technically, it can. And it goes all the way up to 250, which is the higher end of what the heart's even capable of. And in between, you have a lot of overlap. So sinus tach usually tops out around 160, whereas you have atrial tachycardia, which can get way out here in the 240s. I'll actually do a star here. A fib usually likes to stop in the 170s. A flutter may go all the way up to 200s. Junctional tach maybe around 180. And so as long as you can see the P waves, you can tell all of these apart. However, if they're going so fast that you cannot see a P wave in any way, shape, or form, all of a sudden you're stuck with SVT. And so the real challenge winds up being in this range of 120 to 160s, and even a little higher, where you've got so many items that overlap. All of these different rhythms are up for grabs in terms of determining which ones are which. So do your best, come up with the best answer you can for SVT. But keep in mind that, these are those ranges that they all overlap with one another and why the P waves are so important. Decreased cardiac output, CO, may present as which of the following? Will it show up as chest pain? It absolutely can, because that heart may not be getting the perfusion it needs. Hypotension? Absolutely, because if the heart's not putting out enough blood pressure, or not putting out enough force, you might have low blood pressure. Decreased level of consciousness? Absolutely, because you're not getting enough blood flow to your brain. Shortness of breath? Definitely, because it feels like you can't catch your breath, either because blood backing up or because it's not moving well enough throughout your body. And anxiety, you don't feel good. So these folks might even just show up super anxious, and then you figure out all this other stuff. So yeah, essentially all of these are items that may be present with decreased cardiac output. The telemetry tech notifies you your patient has gone from sinus rhythm to atrial fibrillation with rates of 115 to 120s. What first action would be most appropriate? Now, is this non-emergent and you can just have your CNA evaluate the patient? No, this is a rhythm change. It needs to be a nurse who's involved. So, does the primary nurse evaluate the patient and then notify the attending? That's completely appropriate. Do you just call the attending provider right away and don't even look at the patient? Of course not. So, C, off the table. Is change from sinus rhythm to atrial fibrillation emergent? Do we need to call an RRT? Do we notify the attending provider immediately to come evaluate the patient? No, absolutely not. So neither one of those are correct either. It really comes back down to the primary nurse needs to evaluate the patient and then notify the attending. The telemetry tech notifies you your patient has converted from atrial flutter with rates in the hundreds to sinus bradycardia. What first action would be most appropriate? So the question is, has your patient gotten worse or have they gotten better? Sinus bradycardia is a more natural rhythm, and so at that point they've gotten better. So is this an emergency that they've improved? No, it's not. So you don't have to worry about doing an RRT or notifying the attending immediately to have them come look. Now, while this is non-emergent, do you want the CNA to go check on your patient? I don't think so. You as the nurse, it's your responsibility. So between, do you notify the attending about the rhythm change right away? No, you should actually go evaluate the patient first, then notify the attending, because you want to get a fresh set of vital signs and all that good stuff. The telemetry tech notifies you that your patient has been in sinus tachycardia with rates in the 110s, but is now in supraventricular tachycardia with rates in the 150s and 160s. Which first action would be most appropriate? Well, you have to ask yourself, is this emergent or non-emergent? We've got a high heart rate, but you really don't know much more than that. SVT is never good because it's fast, so you're always worried about decreased cardiac output with those patients, so you need to get them evaluated in a hurry. So right away, I'm not going to delegate a CNA to check on that patient. A nurse needs to go to be the first one to look. Am I going to call the attending first and have them look at the patient for me? No, I really wouldn't do that, because that's going to delay someone laying eyes on the patient. So notifying the attending first isn't the way you want to go. At that point, you now have a choice. Do you call an RRT and have the ICU nurse look at the patient, or do you look at the patient first, then call an RRT if the patient's symptomatic? That's the route you need to go. Any kind of delays in checking out this patient are delays. So if you get notified your patient has gone into SVT, it's your priority to get in there and take a look at them as soon as possible, and then you can call for more help if the need arises. So best first action, primary nurse evaluates the patient, calls if symptomatic. The telemetry tech notifies you your patient has been in atrial flutter with rates of about 130s, but is now in sinus bradycardia with rates in the 30s to 40s. What first action would be most appropriate? And the question becomes, is this an emergent situation or non-emergent? Your patient's heart rate has just dropped by 100 beats per minute. That absolutely makes this a critical type scenario. And so if you receive a call letting you know that this has happened to your patient, you're not going to have a CNA take a look. You're not going to waste time notifying the attending first and then going to look at your patient. No, you are going to be the one who goes and evaluates the patient as quickly as possible and then call an RRT if the patient is symptomatic. Now, it may very well happen that someone else can call an RRT for you simultaneously, but that's not your job. You, as the nurse being told that your patient's heart rate's dropped that much, need to go evaluate that patient as soon as possible because we don't want to delay someone laying eyes on them. When providing care to patients in supraventricular tachycardia, SVT, which of the following are priorities for your care? Just look at this list and it's what you would do for any patient, right? If your patient's in SVT, you need to visualize them. You have to go lay eyes. While you're there, you definitely need to check a pulse, collect those vital signs. If there's no pulse, what are you going to do? You're going to initiate CPR. However, you need to confirm if they're DNR, DNI status before you go off and do that kind of stuff. Obviously, if there's no way of knowing, err on the side of a good Samaritan and start intervening accordingly. But if you're able to check for a purple wristband or know what their wishes are, follow them. Are you going to ambulate a patient to the restroom who's in SVT, especially if it's new onset? Absolutely not. There's no ambulation. Keep them in bed. Check level of consciousness, of course, but that's again part of your visualization of the patient. It's part of talking to them and working with them. Now, if your patient is on the floor, are you going to move them to the bed immediately? The answer is no. You're actually going to take care of the patient right where they're at, make sure there's enough help in the room, then maybe you can move them if it's appropriate at that time. But if they fall into the floor, just keep the scene safe. So of this list, I would say it's the ambulate and the move the patient, that those are not your priorities.